So it's an honor to be here today, both to be in Marseille and to be speaking with SESSTIM, a leading public health group both in Marseille and in France, with expertise in social inequalities, in research related to many different things, including migration and health. If my French is very beginner, so I'm speaking in English. If I speak too fast, maybe someone can give me a signal to slow down. So I'm a physician trained in internal medicine. Most of my work has been end-of-life care, palliative care at a public hospital in Oakland, although I've also done primary care. And I'm also a medical anthropologist, and I do research and teach at University of California, Berkeley. So today I'm going to talk through one segment of a research project that I'm finishing, that I wrote a book about, and I'm now doing a visual ethnography film related to. And I hope that you find pieces of the research that relate to your own work and to your lives here in Marseille. And then this year I'm moving into a new project related specifically to the ways in which medical doctors learn to perceive and respond to social differences and social inequalities. So maybe in the spring I can tell you more about that project too. And that project relates both to general practitioners and public health doctors and to specialists, including oncologists, etc. After the talk, I'm happy to answer any questions. So as a physician, I'm trained to give a PowerPoint presentation, which when I'm in the audience, sometimes I find a little bit boring when someone is just using the PowerPoint. As an anthropologist, I'm trained actually to read you a paper, which when I'm in the audience, I find also rather boring. So today I'll do both. There are two primary questions that run throughout all my research. One is, through which mechanisms do social inequalities and social structures lead to health inequalities or health disparities? And the second question is, through what mechanisms are social and health inequities normalized or naturalized? How do they come to be understood as normal or natural, both in society and in medicine and in public health? So in this particular project, I use participant observation ethnography, oral histories, interviews, clinical chart reviews, and media analysis. And you're a mixed group with some anthropologists and some epidemiologists and some health economists. So if you have questions about my methods, let me know. Otherwise, I'll sort of keep moving forward. So you might ask why you should listen to a talk about Latin American migrant farm workers in the United States. So there are a few reasons, some of which relate to Marseille and some of which are differently broad. Undocumented indigenous Mexican migrants, in many ways, are an important population to understand because their lives are impinged on by powerful social, political, and economic structures on transnational levels. They are also the subject of heated political debates in the United States, as I'm sure you're aware, as in France, migrants are. And they're a growing population who have a significant amount of morbidity and mortality that we don't really know that much about. For some quick statistics, the United Nations Population Division, you can also tell me if I'm talking too slow. The United Nations Population Division estimates that there are 175 million transnational migrants in the world, which is 50% higher than a decade ago. And each year in the United States, there are more than 2 million migrant farm workers who are employed each year. The National Agricultural Workers Survey in the United States indicates that over 80% of farm workers are immigrants, 95% of whom were born in Mexico, and over half of whom are undocumented. And it's estimated that there are over 1 million indigenous Mexicans in the United States who speak their primary languages Mixtec, Zapotec, and Triqui, for a few examples. Part of the reason I was excited to come to Marseille, both to Imera and to Pauli Calmette, is also the city of Marseille, the Mediterranean region. Transnational migration is very important in the Mediterranean region, as you're very aware. This is an interesting city in terms of diversity and migration that I'm sure you know much more than I do after I've been here only 3 weeks. There are also many agricultural products that are grown nearby that are sold throughout Europe. And the Mediterranean region has significant experiences related to reception of immigrants. So this is the book that I wrote. I've also published public health articles and medical articles related to it, and this is the project that in many ways is finishing up. So on a national level in the United States, migrant farm workers have very poor health statistics in comparison with other groups. While in the field of public health, the dominant understanding of immigrant health is either called the healthy immigrant effect or the Latino paradox, in which foreign nativity is understood to confer a protective effect. If we consider subgroups of immigrants, we have to critique and challenge this understanding. So to be specific, agricultural workers have an occupational fatality rate over 5 times higher than the national average. In addition, agricultural workers have significantly increased rates of injuries, chronic pain, heart disease, cancer, and stillbirth. Among agricultural workers, migrant and seasonal farm workers have the poorest health outcomes. They and their children have increased rates of many illnesses and diseases. I won't read all of them because it's too much, but it includes HIV, tuberculosis, heat stroke, malnutrition, diabetes, insomnia, anxiety, liver and kidney disease. In addition, farm work has been shown by some research to have a comparable effect as smoking on lung health. But despite such poor health status, migrant farm workers have very poor access to health care. In the United States, nationally, only 5% have health insurance. And even though there's a federally funded program to subsidize migrant health care, it's estimated that this program serves roughly only 10% of the population. In addition, despite all these increased injury rates, farm workers are excluded from workers' compensation benefit from the government, which includes health care. So on to this specific research project. As an anthropologist and a physician, my research involved multi-sited, multi-method investigation fieldwork with indigenous Triqui migrant farm workers from the Mexican state of Oaxaca. I began the research in Washington State, doing interviews, participant observation, chart analysis, spending 5 months living in a labor camp on different strawberry, blueberry, and apple farms, picking strawberries and blueberries alongside the other adults in the camp twice a week, accompanying any of the farm workers anytime they got sick to the clinic or the hospital or social service institutions, and spent the rest of my time interviewing farm managers, farm workers, doctors, nurses. I then moved for 3 months to Central California, living with 7 extended Triqui families, first homeless out of our cars and using a city park bathroom until we could find someone who was willing to rent to people who don't have a credit history, don't have bank cards, etc. And then we moved into an apartment, a 3-bedroom, 1-bathroom apartment with 19 people, and looked for work, usually pruning vineyards in the region. Next, I spent 4 months in the mountain village of San Miguel in the mountains of Oaxaca, Mexico, in the house of one of the Triqui families that I met in Washington State as it was being built, as they were sending money. We harvested corn, took the oxen to pasture, And whenever anyone was sick or in the hospital, I went to the clinic in the little town or went to the hospital nearby. In April of that year, I accompanied 10 of the young Triqui men from the village as they ventured to a border town, made contact with a coyote, a border crossing guide, and crossed the border into Arizona on foot, were apprehended by the Border Patrol and put into detention centers. After my companions were then deported back to Mexico and I was released with a fine, I interviewed Border Patrol officers, border activists, and civilian vigilantes in Arizona before returning to Central California and meeting up with those people who had been deported and then ended up crossing again. And over the last several years, I've spent some time in each of these sites, basically every year, almost every year. So here is a list of the participants in the research, and I'll try to give you a sense of what seems to be going on between these different groups in relation to ethnic interactions, health, social inequalities, and healthcare. So the rest of the talk will involve the analysis of 4 primary findings. First, there's a subtle but intricate hierarchy on the farm based especially in ethnicity and citizenship. Second, the social structure that I just described produces the health disparities that I outlined at the beginning of the talk, especially through mechanisms of living and working conditions. Third, there's a lack of social analysis in the practice of healthcare in the migrant health clinics that often leads to an inadvertent and subtle blaming of the patient for their behaviors or for their culture. And fourth, social and health disparities come to be seen as natural, primarily through metaphors of race and body difference, especially genetic metaphors of race. And I'll elaborate further on these points in the rest of the talk. So the rest of the talk will take place in northwestern Washington state, the Skagit Valley, halfway between Seattle, Washington, and Vancouver, Canada. The Tanaka farm is the largest farm in the Skagit Valley, employing roughly 500 people in the peak of the picking season, which is June through October. The farm is well known for its strawberries, which are from the Northwest variety, and they were developed by the father of some of the current growers. The Northwest variety is red throughout and lasts only minutes on the shelf, unlike the Camarosa variety that we usually buy in the store that's red on the outside and white in the middle, and the middle part doesn't really taste like a strawberry. The Northwest strawberry is used primarily in the dairy business by companies that want to be able to write something like milk, sugar, and strawberries on their labels without having to write a lot of food coloring or flavorings in addition. The Tanaka farm advertises itself as, quote, a family business spanning 4 generations with over 85 years experience in the small fruit industry, unquote. On a practical level, employees on the farm grow, harvest, process, and sell berries, supporting the explicit goals of the company. On another level, of course, the structure of farm work involves a complex hierarchy. The structure of labor is both determined by the inequities in society at large, specifically those organized around ethnicity, citizenship, and socioeconomic status, and it reinforces those larger inequities. The structure of farm labor includes several hundred workers in positions from owner to receptionist, field manager to tractor driver, berry checker to berry picker, and anxieties, privileges, and health status differ from the top to the bottom of this labor organization. Next, I'll sort of run through the organization so you have a sense of it before we analyze the rest of the findings. The 3rd generation of Tanaka brothers make up the majority of the executives on the farm. The others are white American professionals recruited from other businesses. The executives work seated behind desks in private offices and live in their own houses, many with panoramic views of the valley. They work long hours, usually starting before the sun comes up, and they often take a break during the day to work out at the gym or to meet a family member or a friend for lunch. Probably not right now during COVID, but in general, that's true. They worry about farm survival in a landscape of competition and economic globalization where they see other farms going out of business or being bought up by larger corporate farms. The farm president, John Tanaka, explains, quote, "The challenge for us at a management level is that we've got to maintain our fair share of the market. The difference is that in South Carolina, they have federal minimum wage, which is $5.75 an hour. In Washington state, I'm paying a picker $7.16, the state minimum wage, but we're competing in the same market. That's a big difference and a challenge. I would say the largest challenge for survival is offshore competition. For example, China. They could take a strawberry and bring it to San Francisco and deliver it to a restaurant cheaper than we can. In many countries that we're talking about, they don't pay $7.16 in a day," unquote. The executives attempt to run a family farm that can survive these pressures in order to leave something for future generations. John explains, "It's different than other businesses, where you grow a business and then sell out, or you reach a certain profit level that you're comfortable with. In our business, we grow it for the next generation, which means that when I retire, I can't pull dollars out of the company because it would leave the next generation with a big gap. That's what we focus on." The crop managers have private offices in a small field house several miles into the fields from the main office, though they spend a significant amount of time walking through the fields overseeing how people are picking. They work similar hours to the executives, but have somewhat less choice in when they take a break, roughly based on whether the executives are around or not. That's sort of a joke, but not a joke, so testing to see if you're paying attention. The crop managers are all white Americans and live in private houses in one of the nearby towns. The administrative assistants who work seated at desks in common spaces live in relatively simple family houses near the farm, and they're almost entirely white US citizens with a few US citizen Latinx people. The teenage checkers weigh the berries, enforce the farm rules, such as the allowed number of leaves per flat of berry, and spend much of their time waiting. Both the administrative assistants and the teenage checkers worry primarily about the moods and reactions of their supervisors. The other workers live in one of 3 labor camps. The first holds 50 people and is located 100 feet from the road. That would be 30 meters, right? Each shack has heating and insulation, and the field supervisors who walk outside observing and directing the pickers live here. Some treat their workers with respect, while others use outright racist epithets. Both groups are bilingual in Spanish and English, almost entirely Latinx US citizens, along with one Mixteco indigenous man from the Mexican state of Oaxaca. The second camp, located a few hundred feet from the road and holding roughly 100 people, is made up of units with insulation but no heating. This is where those who pick raspberries and apples, as well as a few of the strawberry pickers, live. The raspberry pickers work on this machine and are paid per hour. The apple pickers climb ladders up and down and are paid per pound, and they make the most of all the pickers. These groups are made up almost entirely of undocumented mestizo Mexicans, along with several undocumented Mixtecos and a few undocumented Triqui. Is the word mestizo in English familiar? No. So in Latin America, there are many indigenous groups, native groups, who were there many generations and generations before the Spanish arrived and colonized and settled. And so the main people I work with are indigenous native people, Triqui people, who speak Triqui as their first language, and then they end up learning Spanish, and some learn English. The people who are descendants of Spanish and indigenous people are called mestizo, And so usually when someone talks about Mexican people or Latin American people, usually they mean mestizo people. But I'm trying to be specific. The third labor camp, located several miles away from farm headquarters, holds 250 people. The shacks here have no heating and no insulation, and this is where the majority of the farm's laborers, strawberry pickers who are paid per pound, live. They're made up almost entirely of undocumented indigenous Triqui Mexicans, as well as several indigenous Mixtecos. Those are two different indigenous groups from southern Mexico. Strawberry pickers work outside 7 days a week, rain or shine. They have to bring in a minimum weight of 50 pounds, 50 pounds of de-leafed berries every hour. Otherwise, they're fired and kicked out of the labor camp. In order to meet this requirement, they take few or no breaks from 5 in the morning until the afternoon when the field is completed. Many don't eat or drink anything, so they don't have to take time to use the porta potty, the toilet. They work as fast as they can, picking and running with their buckets of berries to the teenage checkers. A representative description of the struggles of a strawberry picker came from Marcelina, a 28-year-old Triqui woman. It's very difficult for a person here. I came to make money. Like I thought here on the other side of the border there's money, but no. Sometimes the checkers steal pounds. Sometimes rotten berries make it into your bucket. Eat that one, they say, throwing it into your face. They do not work well. This is not good. There in Oaxaca, we don't have work. There are no jobs there. Only the men work sometimes. But since there are many children in my family, the men don't make money for me and my son. That's why I wanted to come here to make money, but no. This is a conceptual diagram of the relationship between status in the vertical axis that relates to respect, health, financial security, control over your own time, and control over others' labor, and then the different columns of body position in work, citizenship, language, and ethnicity. Much of this hierarchy reflects what we know in the United States overall. However, one unexpected finding related to the relative status of Triqui people below Mixteco people, both being indigenous people from the same region of Mexico. In further interviews, many of the white and US Latinx farm employees told me that the Triqui people were, quote, more simple, while mestizo Mexicans stated that the Triqui people are, quote, los indígenas más puros, the most pure indigenous people. Here it appears that different indigenous ethnicities are understood through the classic symbolic continuum from kind of savage to civilized that we obviously need to question. The white American and Japanese Americans are positioned in this hierarchy as and understood to be civilized and modern, and the Triqui people are positioned and represented as the opposite, as backward or simple. And the Mixtecos are positioned in between. In anthropology, at times we'll talk about this as social Darwinism, a way that Darwinism has been taken into understanding different ethnic groups and is part of racism. In many ways, ethnicity, education, and citizenship, I didn't fit in. For the purposes of my research, I placed myself in the housing and occupations of the Triqui undocumented immigrants. I picked twice a week and gained bodily data, such as knee, back, and hip pain. And I often felt sick to my stomach, stressed the night before picking, worried that I wouldn't be able to pick the minimum weight. Usually after picking, for the next couple days, I would take ibuprofen, and sometimes I used the hot tub in the local gym, very aware of the obvious inequality in access to such things. But because of my social and cultural capital, the farm executives treated me as someone out of place, giving me permission to keep my job and my labor camp shack, even though I actually never was able to pick the minimum wage. At times, they even treated me as a superior, asking my advice on the future of farm relations or on housing. Crop managers and supervisors treated me as a sort of jester, like some kind of respected entertainment. Is that word familiar, jester? In the, like, kings and queens used to have someone who would dance around and juggle and they would laugh at them, but that's the jester. They often joked with me and laughed using rhetorical questions like, "Are you still glad you chose to pick?" But while they were asking me, they would actually pick into my bucket to keep me from falling too far behind. On the other hand, the other pickers interacted with me with a mixture of respect and suspicion. Many wondered why there was a gabacho chacan, which is a mixture of Spanish and triqui, which means bald-headed white American, which was my name for many people. They wondered why there was a bald-headed white American picking berries. They'd never seen a white person pick berries before. Several people believed I was a spy for the police, the Border Patrol, or the US government, and other people argued that I must be a drug smuggler who was hiding out from the police or the Border Patrol or the US government. And during dinner one evening in his labor camp shack, Samuel, who's standing up with the hat on, told me about the problems that lack of resources created in their hometown in Mexico, and said that they need a strong mayor, or in Spanish, a strong presidente. And I asked him if he would be mayor someday. But conducting a clear social analysis, he replied, "No, you have to have education and money. You will be presidente of San Miguel Set, and you can do a lot of good. We need a water pump and paved roads." Near the end of my research, Samuel said, "Right now, we and you are the same. We're poor. But later, you'll be rich and live in a luxury house, a casa de lujo." And I explained I didn't want a luxury house. I wanted a little simple house. And I was thinking of a craftsman-style 1920s little house in Seattle or Berkeley where I had gone to school, which for me seems like a simple house. And Samuel clarified his analysis of social structures. But you'll have a bathroom on the inside, right? The social structure based on ethnicity and citizenship not only produces the labor and housing hierarchy that we just went through, but this whole complex maps onto the health disparities that we outlined at the beginning of the talk. The Triqui people inhabit the bottom rung of the hierarchy in farming in this region, with the most stressful, most humiliating, and most physically strenuous jobs, with the most exposure to weather and pesticides. They live in the coldest, wettest shacks in the most hidden labor camp. After the first week of picking, I asked some of the pickers about their experiences, and I'll illustrate with a few examples. One young female picker stated that she could no longer feel anything in her body at all, that it had gone numb. And another said that her knees, back, and hips are always hurting. One of the young men who had been playing basketball before the harvest started explained that he and his friends no longer played basketball because their bodies hurt too much. And Abelino, a Triqui father of 4 who lived near me in the labor camp shack, explained, "You pick with both hands at once, bent over, kneeling like this." And he demonstrated kneeling all the way down. "Your back hurts, you get knee pains and pain here," and he touched his hip. "When it rains, you get mad, but you have to keep picking. They don't give lunch breaks. You have to work every day like that to make anything. You suffer a lot in work." So to summarize what we've talked about so far, the most important processes that are leading from the fundamental social structure of this ethnicity and citizenship hierarchy to the health inequities that we began with appear to be these labor conditions and living conditions. During my fieldwork, many of my friends and family came and visited me while I was living on the farm. and they assumed that it was the farm owner's fault that the pickers were living in such poor conditions and that they could easily rectify the situation. This assumption is supported indirectly by a lot of research on farm work, most of which describe the details of pickers' lives without trying to understand racial capitalism or the larger structure in which it fits. This is an aerial view of this region, the Skagit Valley, leading up to when I began the research. And you can see two things. One is expanding urban boundaries, so the white and black are the two cities. During my research, Walmart and Costco bought land that used to be farms. And then you can also see pretty clearly that some of the smaller family farms are being bought up by other farms such that they become larger and larger and more corporate. The hierarchy on the farm is not entirely chosen or willed by the farm owners or managers, though they play a role in it. Rather, the inequities are driven by these larger structural forces, as well as the anxieties they produce. The stark market competition and precarious future of the farm squeezes growers such that they have a hard time imagining how they can change things on the farm without going bankrupt and selling to a different farmer. In other words, the fundamental inputs into the sickness and health disparities affecting farm workers are these structural, social, economic, political items, and they're not willed by individual agents. At the same time, we have to keep in mind the role that the individual agents, the farmers, play, because they often have a fair amount of say in whether they, for example, in the United States, very few farms allow unions. And in many states in the United States, farm workers are not allowed to organize or unionize. In California they are, but in many states they're not. So we've talked through the hierarchy on the farm and some of the ways in which those structures determine health disparities, and now I'd like to talk some about healthcare. First, I'll talk about the migrant clinics in general before talking through the experiences of two farm workers. Medical professionals in the field of migrant health work under difficult circumstances. Most clinics that serve migrant farm workers have unreliable sources of funding, and many don't have the state-of-the-art technology or medicines. Physicians and nurses in these fields perform many duties for which they're not trained, from requesting free medicines for their patients to filling out social service paperwork. Dr. McCaffrey, a young physician in the Skagit Valley, told me, most migrants don't have any health insurance, so that's even harder because you figure out how to start them on a medication, but you know they're going to go off it again wherever they move to next. In addition, many of the clinicians explained feeling hopeless as they watched the health of their migrant patients systematically worsen. Dr. Samuelson, another physician in the migrant clinic, explained, I see an awful lot of people just wearing out, 40-something or late 30s or early 50s. They're just worn out. They've been used and abused and worked physically harder than anybody should be expected to work for that number of years. They come out with this nagging back pain. You work it up and it's not getting better, and you don't think there's any malingering, which is the medical word for lying. You don't think they're lying. It gets to the point where you have to give them an MRI scan and their back is toast. In their early 40s, they have the arthritis of a 70-year-old and they're not getting better. They're told, sorry, go back to what you're doing, and they're stuck. They're screwed, in a word, and it's tragic, unquote. Continuity of care is also difficult to attain due to the fact that most of the migrant farm workers live several months in one region and then live somewhere else for the rest of the year. It's also difficult because many of the migrant clinics transcribe the names of the patients incorrectly. In Spanish, in a lot of Latin American countries, you have a paternal and maternal last name, but oftentimes they'll have one chart with the paternal last name and one chart with the maternal last name, and information is lost between the two. In addition, very few migrant clinics offer services in languages other than Spanish or English. So if you speak Triqui or Mixteco or Haitian, you are out of luck. Related to languages, the nurse practitioner in the clinic explained to me, quote, "There are a lot of staff who don't want to be bothered getting a trained interpreter. They grab me and say, 'Could you be an interpreter?' But this person has a right to get a real interpreter and not a 5-minute discussion with me when I'm running between my own patients. It's just reluctance. It's just that one more step. It's just racism. It's just being overworked because our system is a total train wreck right now. Are you sure you want to be a doctor?" she asked me. At the same time that most health professionals in this field feel overworked and powerless to change these structural forces that are influencing the health of their patients, many of them explained that they felt a calling or a commitment to work with this population. They explained that this population deserved the best possible health care they could receive, even if they don't have the best private insurance. So I'll move on to talk about one or two immigrant experiences in healthcare. Abelino, a Triqui father of 4, lived near me in the labor camp and experienced acute pain in his right knee when he pivoted from one row to the other picking strawberries. After continuing his work in vain hope that the pain would go away, he told his supervisor about the incident, and the supervisor said simply, "Okay," and drove away. Not sure what to do, Abelino kept picking in great pain. 2 days later, work was abruptly canceled, and Abelino and I went into a general practitioner office. Abelino ended up seeing 4 medical doctors and a physical therapist, usually without a translator in Spanish and never a translator in Triqui. And in the intervening months, he limped around the camp taking care of his kids while his wife picked strawberries. The urgent care doctor in the first clinic explained that Abelino should not work. He should rest and let his knee recover. The occupational health doctor we saw the next week said Abelino could work, provided he didn't bend, walk, or stand. So Abelino went to the farm office to ask for work of that kind, and the bilingual receptionist told him in a frustrated tone, "No porque no." No because no. After a few weeks, the occupational health doctor passed Abelino's care to a busy rehabilitation medicine specialist, who told Abelino and me that he must work hard picking strawberries in order to make his knee better. She asked me to translate into Spanish that he had been picking incorrectly and hurt his knee because he didn't know how to bend over. But notably, in her rush, she had never asked Abelino any details about his work, including how he bent over. And years later, Abelino still tells me that he has knee pain and that, quote, "Los médicos no saben nada." The doctors don't know anything. As someone who was finishing my medical studies at the time, that was disconcerting to hear. I think we finish at 1:30, yeah? Yes. Okay, so I'm not going to talk about the next person. I'll move on to analysis. So aspects of my work build on and critique some of the historical work of Michel Foucault. In his book, The Birth of the Clinic, Foucault describes a theory of the clinical gaze, or the medical gaze. He explains that there was a change in clinical medicine around the time of the advent of anatomic or cadaveric dissection. Whereas physicians used to focus on the words of the patient, the symptoms as expressed by the patient, they began instead to focus on the diseased organs, treating the patient more as a series of objects that make up a body. In Foucault's description, the primary question changed from, quote, "What is wrong?" to, quote, "Where does it hurt?" As would be expected within this paradigm, the rehabilitation medicine physician and the migrant health doctors described earlier saw the tricky bodies in their offices, yet weren't able to engage the human and social contexts that were leading to their illnesses. But since the time of Foucault, the paradigm of biopsychosocial health has been taken up in medicine and public health. Beyond the acontextual gaze that theorized by Foucault, physicians today are taught to see behavioral factors in health, such as exercise, diet, and substance use. Behavioral health education has been added to broaden medical and nursing and public health education. However, without being trained to consider the social, political, and economic structures that shape the illnesses of their patients, health professionals are equipped often to see only biological or behavioral determinants of sickness. Thus, in a sense, well-meaning clinicians are limited to understanding the genesis of the disease to be in the patient, their biology or their behavior, instead of understanding how the social context is causing that. Ironically, the progressive move to include behavioral health in medical education without an inclusion of the ways in which social structures influence health and behavior might be exactly that which limits clinicians to blaming the victims of health disparities. There's a group of physicians who are also social scientists, MD, PhDs, who have been working on proposing a new framework for medical education that we're calling structural competency, to teach physicians, nurses, public health practitioners to understand social, political, and economic structures and to start to imagine how do we intervene. So we've talked through the three of the four primary findings, and now we're to the last one. How is it that stark social inequities and their correlated health disparities are often largely unchallenged and unquestioned? How have these social and health inequities come to be understood as normal and natural both in society and in medicine and public health? Aspects of my work on this question relate to Pierre Bourdieu's understanding of symbolic violence. Bourdieu explained that we perceive the world around us, the social world, through cognitive schema or lenses. These lenses are produced by and reflect the social world to which we've become accustomed. Thus, we often misrecognize the social order as natural because that which we're perceiving matches the lenses through which we're perceiving it. The inequalities comprising the social world are thus made invisible or taken for granted or normal for everyone. When I asked a mestiza Mexican social worker why Triqui people have only berry-picking jobs, she explained, Oaxacans like to work bent over. Whereas, she told me, mestizo Mexicans get too many pains if they work in the field. Later, I asked the farm's apple crop manager why I hadn't seen any Triqui people harvesting apples, which is the field job with the highest pay, and he explained, Oaxacans are too short to reach the apples. They have to use ladders a lot more, and besides, they don't like ladders anyway. He continued that Oaxacans are perfect for picking berries, quote, because they're lower to the ground, unquote, which is the same thing that a California Senator, George Murphy, said in a U.S. Senate hearing about migrant farm labor. These statements show, and these are representative statements that many people said similar things, show a perception of bodily difference along ethnic lines that serve as the lens through which symbolic violence occurs. In this way, each category of body is understood to deserve its relative social position. Because of their natural characteristics, indigenous Mexican bodies are understood to belong picking berries as opposed to other jobs. On the other hand, mestizo Mexicans and white Americans are understood to have bodies that don't fit well in the picker category and belong in other positions. Another time I can talk more about the pesticides that were sprayed in the field while we were picking. Or the fact that the toilet and the hand washing station is in the danger pesticide storage area. So to return to the two questions that we began the talk with, How do social structures lead to health disparities? And why do we as a society and as health professionals or health community seem not to care? We've seen that there's an ethnicity citizenship hierarchy in farm labor. Next, the data suggests that this social structure determines health behaviors and health disparities through working and living conditions. But perhaps most interesting and frustrating is that these inequalities come to be understood as normal and natural. I didn't read many of the quotes where dentists and physicians used genetic metaphors of ethnicity to back up why tricky people have different healthcare and different illnesses also. We've seen that social structures impinge also on migrant health practitioners, such that they tend not to see the social determinants of health. Rather, they often inadvertently and subtly blame the patients for their sicknesses or injuries. More broadly, we've seen that social and health inequities are understood to be natural due to the perception of ethnic body difference. These processes of normalization and naturalization are critical to understand because they serve to justify social structures and health disparities. So if we as a public health community are to work effectively toward improving the health of all, we must engage in further research to uncover linkages among these larger social, political, and economic structures, community-level factors, individual behavior, and health. In addition, we need to develop something like structural competency such that we're able to perceive and respond to the negative health effects of these larger structures. In some ways, this research leads to many different potential points for intervention, from public health interventions beyond to issues of mass media portrayals, to public policy, to globalization. And I'm sure that you in France and Marseille, who know the situation here much better than I do, have ideas about what should be done and how we as researchers might do the kind of research we do to also support social, political, and economic change so that everyone can be healthy instead of only some of us. I hope that my English was understandable enough, and I'm happy to answer questions. Thank you.